Assalamu alaikum and good morning everyone. This is Dr. Roshan Mahmoud Shumi working as a Indo Medical Officer, Department of ICU. Today, 8 December, we will be hosting our scheduled scientific seminar. At first, we would like to thank our Honorable Director Sir, respected teachers, my dear colleagues, and beloved intern doctors for their presence. Welcome you all to our today's scientific seminar. Our today's topic is electrolyte imbalance and its management in ICU. Our speaker, Dr. Sadequel Hassan, working as an indoor medical officer, ICU department, Community-based Medical College Hospital, Bangladesh. And chairperson is our Honorable Professor Dr. M. Khan Sir, Director of Community-based Medical College Hospital, Bangladesh. Co-chairperson is Dr. Ripun Kartik Bhumi, Associate Professor and in charge of ICU, CBMCB. Now I would like to invite our Honorable Chairperson and Co-chairperson to take their seat on the dais.
Bismillahirrahmanirrahim and very good morning. Respected teachers, dear colleagues, ladies and gentlemen. Today we are going to start our presentation on electrolytes. It's quite important subject and I should say it's one of the important subject in all the departments. It starts from the pediatrics to geriatrics. Everybody may suffer from these sorts of problem. It sounds very easy, but not always easy. It's very difficult to manage, as because there are so many causes, and some causes are not so obvious. Then we have to think of many things prior to our management. It's my pleasure and honor to have the chair as chairperson of today's seminar, though I am not the perfect person. Liponkanti would be the best one. Even then, he is with me, so it doesn't matter. As you all know that electrolytes are quite important in the sense that they regulate the pH of our body. Our blood pH is 7.4. If it comes down to 7, then life is impossible. If it goes above 7.7, life is impossible. So both the extremities are near. If it is less than 7, you are not alive. If it is above 7.7, you will die. So it's really very critical situation to maintain it. And especially, Almighty has given us the buffer systems. That's why people can buffer our this imbalance. Anyway, we'll discuss later on, but prior to that, I would like to invite our speaker, today's speaker. Uh,
Dr. Rakib, Dr. Sir Rakibul Hassan, to deliver his speech. Please come to the desk.
we'll get the chance to discuss later on after his presentations. I went through the presentation. That is a very simple and very good presentation. Hope you will enjoy it and try to remember the questions what you want to ask to the presenter as well as to the co-chairperson. Anyway, thank you very much. Let us start and then enjoy this session and then subsequently we'll go for the question and answer session.
Thank you.
As healthcare professionals, we know that maintaining electrolyte balance is crucial in the critical care setting. Electrolyte imbalance can lead to severe complications and significantly impact patient outcomes. Honorable Chairperson, Co-Chairperson, respected teachers, my dear colleagues and beloved interns. Assalamu alaikum and very good morning. I, Dr. Syed Rakibul Hassan, IMO Department of ICU today going to discuss the common causes and types of electrolyte imbalances we encounter in the ICU, how to recognize them, and the latest management strategies to ensure we provide optimal care for our patient. Let's get started. Electrolytes, imbalance and its management in ICU. Definition: an electrolyte disorder is an imbalance of certain ionized salt in the blood. These are sodium, potassium, chloride, calcium, magnesium, phosphate, etc. Electrolytes are ionized molecules found throughout the blood, tissues, and cells of the body. They are cations and anions. General functions of electrolytes: help to balance pH and acid-base levels in the body, facilitates the passage of fluid between and within the cells through osmosis, play a part in regulating the function of the neuromuscular, endocrine, and excretory systems. Specific functions: sodium helps to balance fluid levels in the body, facilitates neuromuscular function. Potassium, main component of intracellular fluid, helps to regulate neuromuscular function and osmotic pressure. Calcium affects neuromuscular performance, contributes skeletal growth, and helps in blood coagulation. Magnesium influences muscle contractions, performs intracellular activity. Chloride regulates blood pressure. Phosphate impacts metabolism, regulates acid-base balance and calcium levels. These are the normal levels of electrolytes. Now I'd like to discuss specific electrolytes in brief. Sodium. When the serum sodium level is more than 145 milliequivalent per liter, then we call it hypernatremia. Causes may be divided into renal and extrarenal. The renal causes are inadequate water intake, increased sodium intake, excessive free water loss, and nephrogenic diabetes insipidus. The extrarenal causes are burn, sweating, tachypnea, and central diabetes insipidus. Symptoms of hyponatremia: restlessness, irritability, muscle twisting, hyperreflexia, spasticity, seizures, with hypotonic losses, signs of volume loss, tachycardia, hypotension, decreased jugular venous pressure, dry mucosa, reduced skin turgor, and thick, doughy skin. Encephalopathy related hypernatremia. Mechanism of action: shrinkage of neuronal cell body, osmotic demyelination. Clinical manifestations are agitation, lethargy, coma, generalized or focal seizures. Mortality rate as high as 50%. Treatment of hypernatremia basically depends on the types. They are acute and chronic, and also we can classify the hypernatremia in hypervolemic hypernatremia, hypovolemic hypernatremia, and also the euvolemic hypernatremia. The acute hypernatremia can be corrected rapidly. Chronic hypernatremia should be corrected slowly. If chronic hypernatremia is rapidly corrected, the osmotic imbalance may cause cerebral edema and potentially severe neurologic impairment. Aim for serum sodium correction approximately 12 millimole per liter per 24 hours. Formula for the calculation: volume in liter to be replaced equal current total body water times sodium subtract 140 divided by 140. Total body water equal body weight times 0.6 in males or 0.5 in females, whereas total body water is typically 50% of total mass in women and 60% of total mass in men. Hypernatremia with hypovolemia. Patients should receive isotonic saline to restore euvolemia and to treat hyperosmolality. After adequate volume resuscitation with normal saline, 0.4% saline or 5% dextrose or both can be used to replace any remaining free water deficit. Hypernatremia without hypovolemia. And these are divided into central diabetes insipidus and nephrogenic diabetes insipidus. Common causes of central diabetes insipidus: traumatic brain injury, anoxic encephalopathy, meningitis, and brain death. The potential causes of nephrogenic diabetes insipidus: amphotericin, aminoglycosides, radiocontrast dye, dopamine, lithium, hypokalemia, recovery phase of acute tubular necrosis. Diagnosis of central and nephrogenic diabetes insipidus. In central diabetic insipidus, the urine osmolarity is often below 200 milliosmol per liter. In nephrogenic diabetes insipidus, the urine osmolarity is usually between 200 to 500 milliosmol per liter. After vasopressin administration in central diabetes insipidus, the urine osmolarity increases by at least 50%, and in the nephrogenic diabetes insipidus, osmolarity is unchanged. Management: water ingestion or intravenous 5% dextrose will result in the excretion of excess sodium in the urine. Vasopressin administration is also required to prevent ongoing free water losses. The usual dose is 2 to 5 units of aqueous vasopressin given subcutaneously every 4 to 6 hours. Hypernatremia with hypervolemia. We can use furosemide in addition free water replacement as 5% dextrose in aqua. Furosemide alone will aggravate the hypernatremia. Dialysis may be required for the patient with oliguric renal failure. When the serum less than 135 milliequivalent per liter, we can call it hyponatremia. Up to 1% of hospitalized patients develop hyponatremia, making it one of the most common electrolyte disorder. Hyponatremia usually reflects excess water retention relative to sodium rather than sodium deficiency. The clinician should be worried about hyponatremia since mismanagement can result in neurologic catastrophes and cerebral osmotic demyelination. These are the types of hyponatremia, and they classified into 3 types: isotonic hyponatremia, hypotonic hyponatremia, and the hypertonic hyponatremia. And these are the predisposing factors of the various types of hyponatremia. Signs and symptoms of hyponatremia. Whether hyponatremia is symptomatic depends on its severity and acuity. Chronic disease can be severe yet remarkably asymptomatic because the brain has adapted by decreasing its tonicity over weeks to months. We can find the patients of hyponatremia with nausea, abdominal cramps, and/or vomiting, headache, edema, muscle weakness, and/or tremor, paralysis, disorientation, slowed breathing, seizures, and coma. Encephalopathy-related hyponatremia. The consequences are cerebral edema, increased intracranial pressure, risk of brain herniation. Symptoms: headache, nausea and vomiting, seizures, coma, and brain death. The risk and severity of encephalopathy are greater with acute hyponatremia. The complications of the hyponatremia is iatrogenic cerebral osmotic demyelination from overly rapid sodium correction. Also, we called it central pontine myelinolysis. Demyelination may occur days after sodium correction or initial neurologic recovery from hyponatremia. The neurologic effects are generally catastrophic and irreversible. Correction of hyponatremia. Treatment depends on etiology and types of hyponatremia, clinical condition, serum sodium level, and ongoing loss. Regardless of the patient's volume status, another common feature is to restrict free water and hypotonic fluid intake, since this solution will exacerbate hyponatremia. Free water intake from oral intake and intravenous fluid should generally be less than 1 to 1.5 liter per day. In hypovolemic patient, require adequate fluid resuscitation from isotonic fluid to suppress the hypovolemic stimulus for ADS release. Patient with cerebral salt wasting may require hypertonic saline to prevent circulatory collapse. Some may respond to fludrocortisone. Hypervolemic patient may require loop diuretics or dialysis or both to correct increased total body water and sodium and treat the basic cause. In euvolemic patient may respond to free water restrict alone. And that is the formula for the correction. If a non-edematous severely symptomatic 70 kg woman with a serum sodium of 122 milliequivalent per liter should have her sodium corrected to approximately 135 milliequivalent per liter in the first 24 hours. Her sodium deficit is calculated as 70 kg times 0.5 times the difference between desired sodium and the actual sodium. For chronic hyponatremia, the plasma sodium should not rise faster than 0.5 milliequivalent per liter per hour, and the rapid correction phase should stop when the plasma sodium reaches 120 milliequivalent per liter. For acute hyponatremia, the plasma sodium can be increased by 4 to 6 milliequivalent per liter in first 1 to 2 hours. However, the final plasma sodium should not exceed 120 milliequivalent per liter. Infusion rate for hypertonic saline. The initial infusion rate of hypertonic saline can be estimated by multiplying the patient's body weight by the desired rate of increase in plasma sodium. For example, if the patient weight is 70 kg and the desired rate of rise plasma in sodium is 0.5 milliequivalent per hour, the initial infusion rate of hypertonic saline is 70 kg times 0.5 equal 35 ml per hour equal 35 microdrops per minute. The plasma sodium is monitored periodically to determine when the target plasma sodium is achieved. Pharmacotherapy for the hyponatremia, we can use demicocycline and the vasopressin antagonist. These are the called veptans, coniveptan and tolveptan. Potassium. If serum potassium level is more than 5.5 milliequivalent per liter, it is called hyperkalemia. Sign symptoms of hyperkalemia: fatigability, weakness, tingling, numbness or other unusual sensation, paralysis, palpitation, difficulty breathing. This is the ECG tracing, and if the hypokalemia level reaches 6 or 7 milliequivalent per liter, we can find the peak T wave. If it is cross the 8 milliequivalent per liter, we can find first degree heart block in the ECG, and if it is crosses the 10 milliequivalent per liter, the complete heart block shown in the ECG, and if it reaches the 12 or more, then we can find the ventricular fibrillation. Etiology of hyperkalemia: inadequate excretion, renal failure, Addison disease, excessive intake, shifting of potassium from the tissue, trauma, especially crush injuries or burn, hemolysis, acidosis, insulin deficiency. Some drugs causes hyperkalemia like digoxin, succinylcholine, beta agonist, potassium sparing diuretics, and potassium-rich diet like bananas, oranges, tomatoes, dates, high-protein diets, salt substitutes, and potassium supplements. This slide was previously discussed. Treatment of hyperkalemia. In mild hyperkalemia, we should stop intake of potassium, stop offending drugs, restrict potassium-rich diet. Moderate to severe hyperkalemia, we can use glucose insulin infusion, sodium bicarb infusion, IV calcium gluconate, dialysis, nebulized with salbutamol, and sodium polystyrene sulfate, that is ion exchange resin, for long-term management. Previously, I discussed this slide. If the serum potassium level is less than 3.5 milliequivalent per liter, it is called the hypokalemia. The causes are increased potassium losses. Extrarenal causes is diarrhea. The renal causes are renal tubular acidosis, polycystic kidney disease, and some drugs. Endocrine causes are Cushing disease and hyperaldosteronism. Decreased stores like malnutrition, and shift to intercellular compartment like alkalosis and hyperinsulinemia. Signs and symptoms: muscle weakness, fatigability, muscle cramps are frequent complaints in mild to moderate hypokalemia. Gastrointestinal smooth muscle involvement may result in constipation and ileus, flaccid paralysis, hyporeflexia, hypercapnia, tetany, and rhabdomyolysis may be seen with the severe hypokalemia. Here we can see the ECG tracing. In hypokalemia, we found slightly peaked T wave, slightly prolonged PR interval, shallow T wave, ST depression, and prominent U wave. Treatment of hypokalemia. Oral potassium supplementation is the safest and easiest treatment for the mild to moderate deficiency. Intravenous potassium is indicated for patients with severe hypokalemia and for those who cannot take oral supplementation. For severe deficiency, potassium may be given through a peripheral intravenous line in a concentration up to 40 milliequivalent per liter and at rates up to 10 milliequivalent per hour. Concentration up to 20 milliequivalent may be given through a central venous catheter. Continuous ECG monitoring is indicated and the serum potassium level should be checked every 3 to 6 hours. Magnesium deficiency should be corrected, particularly in the refractory hypokalemia. Formula for the correction of potassium: required potassium in millimole equal 0.4 times weight times difference between desired level of potassium and measured potassium level. Deficit corrected over 24-hour period. The usual replacement fluid is potassium chloride, which is available as a concentrated solution in ampoules containing 20 milliequivalent of potassium. These solutions are extremely hyperosmotic and must be diluted. Rate of replacement. The standard method of intravenous potassium replacement is to add 20 milliequivalent of the potassium to 100 ml of isotonic saline and infuse this mixture over 1 hour. The maximum rate of intravenous potassium replacement is usually set at 20 milliequivalent per hour. Dosage rate of 40 milliequivalent per hour may be necessary and the dose rates as high as 100 milliequivalent per hour have been used safely in central venous line. Infusion through a large central venous vein is preferred because the irritating properties of the hyperosmotic potassium chloride solution. Delivery into the superior vena cava is not recommended if the desired rate of replacement exceeds 20 milliequivalent per hour, because there is a risk of an abrupt rise in plasma potassium in the right heart chamber. severe enough to produce acetone. Calcium. If the serum calcium level is more than 10 mg per deciliter, we can call it hypercalcemia. The causes are parathyroid excess, multiple myeloma, vitamin D excess, sarcoidosis, subcutaneous fat necrosis, Williams syndromes, thyrotoxicosis, prolonged immobilization, metastatic cancer, multiple bone fractures, milk alkali syndrome, Paget disease, some drugs, excessive use of calcium containing supplements, certain over the counter medication like antacid may also cause hypercalcemia. The clinical features are fatigability, constipation, depression, confusion, muscle pain, nausea and vomiting, dehydration, arrhythmia, urinary stone, nephrocalcinosis, increased micturition, stupor and coma if the serum calcium level is more than 15 mg per deciliter. The management of severe hypercalcemia, the first line drug is bisphosphonate. We can use calcitonin as the second line drug, but tachyphylaxis is more common. We can use furosemide with the addition of isotonic saline, and in the lymphoma and myeloma patient, we can use glucocorticoids. If the serum calcium level is less than 8 mg per deciliter, then we call the hypocalcemia, and the causes are vitamin D deficiency, prolonged phenytoin medication, idiopathic hypercalcemia, renal tubular necrosis, furosemide therapy, abnormal metabolism, increased losses, hypomagnesemia, hypoparathyroidism, pseudohypoparathyroidism, hypoproteinemia, acute pancreatitis. The clinical features: muscle cramps and spasms, tetany and or convulsion, mood changes like depression or irritability, dry skin, brittle nails, facial twitching, latent tetany, Trozier signs and Chauvet signs. Management of hypokalemia. 2 ml per kg of 10 mg calcium gluconate slowly IV under cardio monitoring. Later oral calcium supplement 40 to 80 mg per kg per day. Obviously treat the vitamin deficiency. This slide I discuss later. Magnesium. In adult, magnesium is distributed in bones, muscle, soft tissue, red blood cell and plasma. The serum magnesium level is previously discussed. Magnesium deficiency, hypomagnesemia is reported in as many as 65% patients in ICU. The predisposing factors are drug therapy like furosemide, aminoglycoside, amphotericin, diarrhea, alcohol abuse and diabetes mellitus. Clinical manifestation: arrhythmia, torsades de pointes, neurologic findings, altered mentation, generalized seizure, tremors and hyperreflexia. Magnesium depletion is often accompanied by the depletion of potassium, phosphate and calcium. Replacement protocol for hypomagnesemia: mild asymptomatic hypomagnesemia. The following guidelines can be used for a serum magnesium of 1 to 1.4 milliequivalent per liter with no apparent complications. Assume a total magnesium deficit of 1 to 2 milliequivalent per kg because 50% of the infused magnesium can be lost in the urine. Assume that the total magnesium requirement is twice the magnesium deficit. Replace 1 milliequivalent per kg for the first 24 hours and 0.5 milliequivalent per kg daily for the next 3 to 5 days. In moderate hypomagnesemia, we can use 6 gram magnesium sulfate and infuse over 3 hours, follow with the 5 gram magnesium sulfate over the next 6 hours and continue with 5 gram magnesium sulfate every 12 hours for the next 5 days. Life-threatening hypomagnesemia. Infuse 2 gram magnesium sulfate intravenously over 2 to 5 minutes. Follow the 5 gram magnesium sulfate over the next 6 hours and continue with 5 gram magnesium sulfate every 12 hours for the next 5 days. Magnesium excess. Accumulation occurs much less frequently than magnesium depletion. In one survey, hypermagnesemia was observed in 5% of hospitalized patients. The predisposing factors are renal insufficiency and hemolysis. The others are decay, adrenal insufficiency, hyperparathyroidism, and lithium intoxication. The clinical consequences of progressive hypermagnesemia are listed. If more than 4 milliequivalent per liter, we can find the hyporeflexia. If more than 5 milliequivalent per liter, first degree heart block can occur. More than 10 milliequivalent per liter, complete heart block, and more than 13, it may be cardiac arrest. Management. Hemodialysis is the treatment of choice for severe hypermagnesemia. Intravenous calcium gluconate can be used to antagonize the cardiovascular effects of hypermagnesemia temporarily until dialysis is started. If fluids are permissible and some renal function preserved, aggressive volume infusion combined with furosemide may be effective in reducing the serum magnesium level in less advanced cases of hypermagnesemia. If the serum phosphate level less than 2.5 milligram per deciliter, it is hypophosphatemia. They are result from intracellular shift of phosphorus, an increase in the renal excretion of phosphorus, or a decrease in phosphorus absorption from the GI tract. The predisposing conditions are glucose loading, respiratory alkalosis, beta receptor agonist, systemic inflammation, phosphate binding agent. Hypophosphatemia is often clinically silent, even when the serum phosphate falls to extremely low levels. Phosphate depletion has several effects that could impair energy metabolism. These are impair myocardial contractility and reduce cardiac output, hemolytic anemia, oxyhemoglobin dissociation curve shift to left. Therefore, hemoglobin is less likely to release oxygen to tissue and reduce the availability of cellular energy. The phosphate replacement therapy, we can use sodium phosphate and potassium phosphate. Hyperphosphatemia. Most cases of hyperphosphatemia, the result of impaired phosphate excretion from the renal insufficiency or phosphate release from the disrupted cell like rhabdomyolysis and tumor lysis. The clinical manifestation, formation of insoluble calcium phosphate complexes and acute hypocalcemia with tetany. There is little information about the prevalence or significance of this manifestation in ICU patients. Management. There are two approaches to hyperphosphatemia. The first is to promote phosphate binding in the upper GI tract, which can lower the serum phosphate level, and even in the absence of the oral intake of phosphate. We can use sucralfate or aluminum containing antacid can be used for this purpose. In the patient with significant hypocalcemia, calcium acetate tablet can help raise the serum calcium while lowering the serum phosphate. Each calcium acetate tablet contains 8.45 milliequivalent elemental calcium, and hemodialysis is the choice for patient with renal failure. Thank you all.